It is a great honor to be here today. Thank you for the invitation. Thank you for the fabulous conversations that we've been having over the last day, including the AI and Health Day that we had yesterday at the School of Medicine. So, and thank you, Ariel. I'm a sociologist, and I'm here really to speak to this word that we have in the title of today's event about expectation. So I've spent time studying how people think about their own data and the kinds of self-tracking projects that they do. I worked for 3 years on a project with Intel on the future of these commercial-grade devices, and my remit really was, how are doctors going to respond when we all, like Rachel Kalmar here in this photo, have our own personal self-tracking data that we bring in to the clinical space? Are clinicians going to reject this data? Are they going to be territorial about this kind of data? Or are they simply not going to care? So what I really want to think about is, with you, is when we're talking about data transformations of health, can we look at this interaction between people and their expectations for how they have clinical conversations and what they want to have happen with their data, and the ways in which perhaps those expectations aren't being met, and maybe those expectations are being taken advantage of. So that's kind of the broader scope of what I want to talk to you this morning. But first, a little experiment, and I want to see a show of hands. So here we have, I love this photo because it's a designer of fitness trackers. And in our 3-year study, we started looking at how fitness trackers would be a model for thinking about consumer biosensing. And as you all know, consumer biosensing isn't really here with us yet. We don't have these kinds of off-the-shelf consumer-grade technologies that are gathering blood, sweat, and tears and giving people some kind of biometric from that data, but they're coming. So, fitness trackers. How many of you have used a digital device, whether a wearable or your smartphone, to keep track of some kinds of health or wellness information? Show of hands. Okay, keep them up for just a moment. Look around, everybody look around. When I started this project, usually only about 10% of the people had them up. Keep them up, please. How many of you still use that device on a regular basis? My talk is done. You can put your hands down. So we know that there has been an explosion in this self-directed tracking. And we also know that about 60% of these devices and practices really only stay used for less than 6 months. So something is going on where people are either getting their needs met from a short self-tracking experiment that teaches them how much activity they're getting in their day, or whatever their kind of goal of that tracking experiment is, or the data aren't meeting their needs. And this is where I want us to use this process as a bit of a thought experiment for thinking about digital health more broadly. We heard great talks this morning, really incredible talks about big data and global public health, and the shocking news that what we have thought of as first world problems, these problems of obesity, these problems with high blood pressure, these problems from diseases that we know individual behavior can help mitigate, are now global public health problems. So on the one hand, we see the rise of conditions where people's individual behaviors could help them lead healthier lives. We see the rise of new tools and technologies to help them make those choices. And yet something's not happening in that connection. Why? Might be the answer that a sociologist would ask. So one of the things that I did with this project was think about how data are talked about, how people have certain kinds of expectations. And I spent a lot of time with people working in the digital health space, designing technologies, and listening to what they wanted the digital health data, digital wellness data to do, how they thought it might transform clinical conversations, nudges for personal choices and actions, etc. And so I worked with a designer to come up with really a model. So if our data is part and parcel of a larger economy of being bought and sold, if data really is this kind of object in an economy where, it's transferred to third parties, people don't fully understand what it is, what would it look like if it were a product? What would it look like? What would data look like if it were on your supermarket shelf? And so working with a package designer, we came up with this data box, right? What if data were simply bought and sold like a laundry detergent? And I use this image simply to introduce the kind of 3 key points from my field of science and technology studies and the sociology of data that I want to bring to audiences like this that are people generally interested in health. And the first would be that the data about people are made, right? They're made, not found. And that this is an important point in designing kinds of programs to help people live healthier lives based on the data that they have about themselves. The second would be that data do not simply equal action, that simply because we gather data, simply because there is data, it doesn't necessarily lead to a set of decisions and actions in place. And this has enormous implications, I think, for the inequalities of health, and we'll talk about that point as well. And then finally, data about people really aren't off the shelf. We just had a fabulous talk about this drive to generalization and the drive to make equivalent different kinds of conversations, different kinds of expectations for data. But once we begin to recognize that individual context and environment have an enormous impact in how people make sense of their own data in their own lives, then we begin to open up new possibilities, I think, for digital health. So let's take the first point. In our book, Self-Tracking, we wrote this really as an explainer for the public about the rise of self-tracking, historical precedents for self-tracking data, and we focus on health and wellness tracking, although we use other kinds of self-tracking projects. In the book, we follow the community quantified self and look at some of the sometimes wacky experiments that they do. And one of the key insights that we want to bring with this book is that when people set out to do self-tracking, they are making data not just with those devices, like the ones we saw strapped to Rachel's wrists, but they're making it also with the practices that they have in everyday life and the communities with which they try to make sense of that data. And this connection between the technologies, the everyday practices, and the communities ultimately shape how people expect their data to move, what they expect and want from their data, and how they make sense of it, what they can actually do with these kinds of data. One physician we interviewed early in the project, when we said that we were working on this project on self-tracking data, we then asked him, so how are you going to respond when someone brings in their smartwatch and says, "Doc, what do you think?" And he said, well, first, what condition do they have? Which to us as sociologists, we're like, condition? Why would you ask that question? That was supposed to be a joke. Little relief. So from our point of view as advocating for the kinds of practices that we could foresee were coming, we said, no, people are going to track things about their health, and they're going to want some interpretation about it. And he said, this beautiful quote, he said, I know what to do with 3 blood pressures taken in my office. I have no idea what to do with 20,000. We know that many people are gathering data that might help them change their lives. And yet, the kinds of communities that they have to bring medical insight to that information are now lacking in the current moment. Let's look at 3 stories from the book. This is Chiara. She's an economist, incredibly sophisticated with data. She is what we might say these data elites. She's wearing a now out-of-business self-tracking watch, the Polar Watch, which she really loved because it gave her the clearest access to raw data. And being an economist, working with data for a living, this is what she wanted. What we've learned from interviewing dozens of people in quantified self communities, people who are managing chronic conditions in their daily lives, and doctors who are trying to improve patient-doctor communication, is that these self-directed experiments change the possibility of who asks questions. Now, for some, in the quantified self community, these questions are a little wacky. If you're a scientist, they're not really valid. For example, if one were to take an example from a quantified self demonstration, if one were to track which cardinal direction you were standing over the course of the year, could you tell a story about how facing north makes you less depressed? Yeah, sure, maybe. That may not be the kind of question that a neuroscientist would ask, but it is the kind of question that someone has asked about their health, and they are asking about their life, and they're trying to make some kind of meaning. And so the possibility of having kinds of data that people can query and ask new sets of questions opens up new kinds of possibilities. So one of the arguments we make in the book is that, well, maybe these fitness trackers that get left behind after 6 months are not allowing people to continue asking the next question. And it suggests that perhaps we need to think about this not as a public health nudging device where health experts are pushing people to make healthier choices, but rather, can we think about these self-tracking devices as new ways to open up scientific engagement and scientific inquiry more generally? This is Hugo Campos. Hugo became an activist for the right to access his own data. He had an implanted defibrillator, and when he lost his health insurance, this is, of course, a US story, when he loses his health insurance coverage, he wants to be able to monitor his condition and to see when his defibrillator is firing. He also wants to ask questions if there's certain foods or certain moments in the day that causes his heart condition to be worse. So is eating a ham sandwich at lunch, for example, something that might trigger an episode? So he did what any reasonable person would do. He went to his doctor and he said, I'm about to lose my health insurance. Can you please help me get access to this data? The company denied his request, and he took this request all the way to the Obama White House, where he became a public advocate for people's rights to data from their implanted medical devices. Now, he said, it's my body is producing this data, it should be mine. The company finally relented and gave him access to the data, but they didn't change their overall policy, so his victory was a bit hollow. It was a victory for him personally, but not for patients in general. And so the moral of Hugo Campos' struggle about getting access and control over his data is that we need to be careful when we're thinking about digital health, that we're not disguising a sense of empowerment and control over data as something that really is a burden that we're placing on individuals, that we're actually addressing the core underlying problems around equity and justice in health, and not simply saying individuals can take more control of their health if they can take more control of their data. And finally, this is a picture from our study from a Medicare Demonstration project. And this was a study of a telehealth program in rural eastern Washington with elderly patients who were struggling with at least one chronic illness. And in this study, time and again, people came back to photographs and experiences of these. So this is this is kind of the flagship photo from this telehealth study, where care workers didn't actually see their patients in person that often, but they used this moment to think about how the data that they shared on a daily basis became this possibility and moment of connection. And so when we think about these kinds of vast amounts of data that are being collected about us in our name, the kinds of social media data that might be marshaled for public health, we need to remember that these kinds of data can be, they can serve as a possibility for more connection and better conversations with care providers, or they can be seen as something that's taken out of context about us and jettisoned off and speaking about us, not for us. So now I want to talk about my second point, really, this question that data do not equal action. In one of our first interviews of the project, we went to a physician and we said, so there's going to be all this great new data about your patients. And very quickly, he said, I don't need data. I need resources. And this is striking, and it was very striking for my Intel collaborators, because the idea that data are not a resource was shocking, right? That's heresy in Silicon Valley. And yet, when you talk to overburdened clinicians, they often, as we heard from the gentleman earlier, they're dealing with fuzzy problems, and it's not necessarily better, finer-grained data that's going to help them solve those problems. Not in all cases. I want to be clear not to overstate this point. That the data, because data are collected, doesn't necessarily lead to the fact that more interpretation and better interpretation can help improve people's lives. And again, I'm talking about the clinical experience, not necessarily in larger scientific discovery or in terms of these larger public health issues. So this is the dashboard. This is the desk of the one of the care workers, the nurse practitioner care workers that was in our Medicare telehealth study. And what you see is actually a very old system. It's not smart, it's not AI, this is not the AI apocalypse. It was simply a dashboard that parsed data that the elderly participants would enter in every day. And these devices they were using were pre-smartphone era. So these were very simple to use devices that didn't assume that they had wireless or internet access in their homes. So on the top row, we see the data for Mrs. Jones, a pseudonym here. And Mrs. Jones always showed up as red. And the care workers all knew that. They knew she showed up as red because the system was built to say that if someone weighed under 100 pounds, that was enough to trigger a follow-up phone call. You need to check in on this person who is elderly, and in her case, slight and small. And yet, what else do we see on the page? We see this list that the care worker has put in front of her to do her follow-up calls and her follow-up interviews. So the data really became the starting point, not the end point in clinical care. It became the excuse for a conversation that would happen. And frankly, it was probably that daily conversation that helped the people within the study improve in their outcomes. So the study actually showed vastly improved patient outcomes, but it was expensive. And Medicare stopped the project. Why? Because the data themselves might have been relatively inexpensive to collect, but putting medical expertise and interpretation into that moment and having that conversation available to patients as an extra level of care may have improved outcomes, but it meant that there had to be other kinds of resources, time and clinical time, that were brought to that interaction. So that these actions, deciding what to do about the data, actually were costly. And this would be my second caveat that I would say about how we need to think about the expectations of digital health, that just because we can collect the data doesn't mean that we can provide care around these data, and that expectation needs to be monitored and managed. And finally, my last point about these kind of 3 points are about how data about individuals really need to understand context in their own lives and how they're not on the shelves. This is the logic model from a program at Cincinnati Children's Hospital through C3N. And they make this argument that data really fundamentally are a communicative process. That if we begin to shift our focus from the kinds of daily data as giving us better and more information, and rather as data giving us the possibility to connect to our patients and to create new ways to collaborate with our patients, then we might have a different kind of model about what personal self-directed tracking would look like. So this notion matters because the context in which the data are collected are contexts of people's lives in which they are the experts. So just as Hugo Campos wanted to be able to look back at his own data and say, on Tuesday, I was in a stressful meeting, he understands points and contexts about things in his own self-tracking that no scientist would be able to understand, right? That he's got that knowledge. And so once we begin to think about this notion that the context for people's data is as important for that interpretation and sense-making in their own lives, and as important in their own choices and actions, and deciding what choices and actions to do in terms of that data, then we open up new kinds of possibilities for engagement. So, what should we do? Based on this study that we did on personal self-directed self-tracking, I've got a call to action for digital health and the ways we need to be really conscious of the kinds of data we marshal to speak for people. So first, what we see time and again, and what we've learned from the quantified self community and from the Cincinnati Children's Hospital study, is that healthcare providers and patients really need to be involved and at the table when thinking about kinds of data that can be used for health. It's wonderful to begin to think about how trace data, say from social media, might give us insights to populations. But when we're bringing data into having conversations that influence clinical decision-making, we need to be sure that we're capturing that individual context within the moment, within the data that is telling us. Second, these consumer-grade devices are opening up phenomenal possibilities for new kinds of data that can really help people manage their conditions better, make discoveries about themselves, choose to lead healthier lives. But the devices must absolutely build privacy and security into the very hardware elements of those devices. When such data can lead to inferences about our health, I would argue passionately that we need to protect those data like we do health data. So if certain kinds of keystroke patterns may be reflecting that one is about to have a manic episode, say, this is actually, some of you may know this study, we need to make sure that people's rights to privacy of their health data are protected in those environments. Third, we know that there are existing inequalities in health that technology has not yet been able to help us solve. We have persistent inequalities. When Dr. Lopez showed the map of the United States, you might have been able to tell I'm American. When Dr. Lopez showed the map of the United States, I saw my home county lit up in red, right? We know what is the social determinants of health in poor areas are not questions that are going to be solved simply by adding and throwing social media data and smartphones at the problem. It's not an AI problem. It's not an information problem, right? It's not data, it's resources. But what we don't know yet is how these data and how the existing inequalities will change and shape the models that we use for going forward. So if we build models for the state of health based on social media data, are we accounting for the inequalities of who does and doesn't participate in social media? Are we accounting for the inequalities that are already driving the differences in our data? And are we building models that appear to be objective when really they're built on biased data? So I'm not saying we can eliminate that bias, but we actually need to be very careful in how we think about where bias gets amplified through the appearance of a seemingly objective technological AI models. Fourth, and perhaps most important to the people that I studied in self-tracking, access and control over data and data about ourselves and data about our health is fundamental, and that access and control should be regardless of the genesis of the data. So if data about me from my smart devices is telling me something about my health, I should have the same rights to control and access to that, and controlling who sees that and what they can do with that data, if that data is saying and inferring something about my health status. And finally, we're not going to have digital health that encourages patient behaviors, healthy behaviors, unless we can assure freedom from the potential harms of these data. So when fitness trackers and activity trackers are subpoenaed to be used in criminal cases against the people who used them for health reasons, when we see subpoenas to, say, smart home speakers that allow for very intimate details of people's lives to be used against them, we're seeing a kind of self-incrimination by our data. And we're seeing a self-incrimination that many people feel quite rightly threatened by. But it also cuts the possibilities that we have for extending the enormous potential for creating positive outcomes through encouraging healthier behaviors through this kind of self-tracking. And with that, I thank you for your attention, and I'm looking forward to your questions.
Thank you, Gina. Yeah, so we have 5 to 10 minutes for questions. There are 3 mics in the room, and yeah, please keep your questions concise, and please in the middle.
Hey. Hi, my name is Cameron. I'm an undergraduate student in Health and Society, and my question is, how far away are we from getting like a world digital data policy? Like we have the World Health Organization, we have the World Bank, and they're respected in most areas, but like a perfect example is that every other Tuesday, Doodle and Facebook get fined in the UK, but those fines don't happen in North America.
Yeah, so what's going to happen with bringing world digital policies in kind of alignment? I will say and I'm not the policy expert. We have other policy experts in the room, but I will say there's a couple of ways to go about thinking that. One is there is a de facto health privacy standard now that is global that's called HIPAA, based on a US law, was not designed to be a health information global standard, and yet because there is a clear checklist to make something HIPAA compliant, we see HIPAA used as a security standard in cases where data are not necessarily being collected about US citizens in their clinical care conditions. So we can see the repurposing of some of these standards, and I think we're going to start to see more of that. So I actually think we're going to, that GDPR, the General Data Protection regulation that came out in the EU, I actually think GDPR is going to change some of the terms of the debates there. So on the one hand, you'll see jurisdictions that push for certain kinds of data protection that have spillover effects. Now, what does this mean if one is, say, a small country? And even within the EU, some of the small countries are starting to have some of these conversations, right? So some of the questions around languages and access to language. For example, Iceland is pushing on some of these. So is Silicon Valley going to shift their policy because Iceland puts in a particular regulation? Maybe not, but if larger trading blocs can kind of band together, I think we can see some of those actions.
Yeah, Bill.
This might not be a fair question to throw at you without warning, but what's, just reading the newspapers, what's the deal with Huawei, the Chinese telecom company, and is it dangerous? And just in relation to your talk, and you may say, I don't know, and then another question can follow. But.
No, I'm gonna do that thing where I pivot ever so slightly, and I say, oh, Huawei, and then let's talk about China. So let's talk about China. What I'd like to do, rather than talk about device security and insecurity, which is partly what's behind your question, right? So as you may know, this is a smartphone maker whose phones are not legal to be sold in the United States or Canada. Is that true? Yeah, you can buy them in Canada. Can't buy them in the US, but you can buy them in the UK. And that is in part because of concerns around base level security. I think the question to ask is first, if we're developing these large cultural, political blocks of policies around information technologies, say a Silicon Valley block that North America and Europe have bought into, we also see a block that is China. And that when we're working with thinking about the future of the internet, we may actually be thinking about multiple internets, and we may be thinking about multiple types of ways that these data are used and marshaled. So I think we need to hold up the best of the values that around privacy, protection, around innovation, around preserving democracy that we see built into some of the kinds of conversations we have about a Silicon Valley way of thinking. And that's as important for thinking about global public health through digital health as some of the other kinds of phenomenon. So when these tools and devices are used to surveil and control their population, it's going to be hard to use them as objective healthcare measures in trusted, honest, secure ways without naming any particular company that may or may not be violating that.
Thank you. In the middle here.
Thank you so much. Very inspiring, and I think you ticked off pretty much all of the concerns that I feel as I look forward. My name's Anne Toohey. I'm with the Brenda Strafford Center on Aging. And I'll quickly recount, I have an acquaintance in a different province. Some of what you've raised is already upon us. I watched her shaking her smartphone up and down because her insurance policy rewards people who maintain 10,000 steps for multiple amounts of days. So, and this is a fairly active person, but so some of these potential harms are already here. I guess that's part of a comment and a question because, there's a lot of interest in the gerontology, geriatrics around increased monitoring as people age, and I guess fitting into kind of the sociological paradigm. What are your thoughts around continuous monitoring and the options to opt out?
So I have a doctoral student in Singapore right now, and talk about, there's one way to talk about Singapore as an authoritarian regime. There's another way. Singapore is really selling itself as smart city, smart nation, right? They're trying to build the smartest population in the world. They are in their public housing, which most people in Singapore live in. They are building now all new tower, HPD tower blocks actually have integrated smart home sensors, and that they're continuing to think about how you do continuous monitoring for the elderly. So one of the surprising, this is, she's literally just back from her first field work, so this is brand kind of new insight. One of the things that she was shocked to find is that you have this great emerging data about elderly people in their homes, and how is it being used? It's actually being used as an in-out board for the caseworkers so that they see when their clients are in their home. That's the only way the data are being used now. So we're gathering more data than we can actually bring sense and sense-making to. And I think we need to be very careful because the kind of imaginaries that people have about how they're gathering data can do real harm. So another case from geriatrics is a study in Seattle that was looking at aging in place and sensing, found that the elderly participants one elderly participant was refusing to take a shower because he thought that there were sensors in his bathroom and that were monitoring him. So even though he had gone through informed consent, even though he was a participant in a university scientific research project, even he didn't fully understand. So we have to do more education, and we have to address fully these practices of everyday life in how people understand this data around them. And we need to fight for the kinds of rights to privacy protection, access, and control that will really give people the autonomy to shape their futures in these digital health environments.
Okay, I think we have a couple more minutes, 2 or so. Yes, over here, please.
Thank you for an excellent presentation. Very much enjoyed your presentation yesterday also, actually. Your comment on self-incrimination with the data that I'm generating got me thinking if I would still be protected under the Fifth Amendment rights that I have.
That's a great question. I don't know. But yes, right now that these data are being used by law enforcement to help help figure out whether someone has committed a crime and whether they can be implicated in being at a certain place at a certain time. So I think we do need to be, from a society point of view, we need to actually think about if that's the kind of future that we want, and especially if we want to encourage the use of such devices to help people direct their own lives to lead healthier behaviors. We're not going to be able to do both of those paths. I think final
Sure,
question.
we only have 1 minute. Yep.
Thank you. It's an excellent talk.
Thank you.
So my name is Vineet, and I'm with the Alberta Health Services and University of Calgary. I'm a scientist. So, you briefly alluded to that data is not equal to action. So in light of AI and big data hypes that we are witnessing, I want to know your thoughts about non-action on social determinants of health. Is it the lack of data, or is it the lack of willingness at the appropriate levels to do some meaningful action? And then my sub-part of that question is, in your experience or opinion, do you think that AI has the capability or capacity to perpetuate inequity in the society?
The short answer to that last question is yes. The answer to your first question, I think, is best summed up by a wonderful psychiatrist who was with me at the Medicine X conference at Stanford several years ago. This is a story from the book. She stands up in the middle of a talk from one of these activity device makers, exercise device makers, and he says, data equals knowledge, and knowledge equals change. And she was like, excuse me, I'm a psychiatrist, and I'd be out of business if that were true. And so I think I pushed this back to a room full of people interested in improving health and healthcare outcomes. We know that these growing epidemics are not necessarily ones that are, that these biggest causes of death globally are not necessarily ones that we need better data on. We know that individual action can lead to change, and that's actually, I think, where we have to do our work. We have to think about how do we motivate people to lead healthier lives, and we're not going to do it in a world in which we assume that if they strap a device on their wrist, that they'll suddenly get healthier. And with that, I'm out of time. Thank you.
Thank you, everyone. Thank you, Gina.